Okay, so look, I get this topic every year or two, and sadly it's a grim topic that somehow Emma asked me to talk about. But we have to talk about it. We can't get complacent about this topic, and I'm guilty of that myself. We're all guilty of it as doctors, and possibly as carers and parents, we're guilty of forgetting about this as well. So every 2 years, unfortunately, I have to put up with this talk, possibly from me or others, and we just can't afford to get complacent at all. But let's start with a straw poll. Who's heard of SUDEP in the room here? Everyone? Okay, who hasn't heard of SUDEP? Okay, good. So a few people we can educate maybe. Where'd you hear, for people who heard it, did you hear it from your neurologist or, how many people heard it from your neurologist first? Okay, a few. Right, a GP? Anyone hear it from their GP? Okay. Other patients? Okay, yeah, so other patients, sort of. Yeah, okay. And how many in this room have got tonic-clonic seizure or cares for someone with tonic-clonic seizures? Okay, so most of the room. And we'll come back to why those questions are important. So let's start with just an introduction and a definition of SUDEP. And most people probably know what this means now, but if you don't, it's an acronym. So SU, S-U, sudden, unexpected. And that can be a witnessed or unwitnessed death, but it's sudden and not an expected death. So someone would say cancer who dies related to a brain tumour or something like that, that's expected. Even though they may still actually die of some complications of seizures, it can get a bit tricky in defining them as whether it's SUDEP or not. Death, obviously, but that's excluding patients with trauma or drowning, and an individual with epilepsy. And there doesn't have to be evidence of a seizure immediately prior, but generally that's the case. And obviously, people who are in status epilepticus, one seizure after another, that's not included in the definition of SUDEP. And post-mortem, I'll come to that in a minute, but post-mortem, if done, shouldn't find any other cause. And for studies, we define SUDEP into definite or probable or not SUDEP. And so if someone has a post-mortem, they've died, they've got epilepsy, they've had a post-mortem, and another cause is found, it's not SUDEP. And that's quite tricky because you don't quite know. There might be some abnormalities in the heart, but with some witnessed, you're not sure, but that's not defined as SUDEP for studies. If the post-mortem is done and there's no other cause of death evident, that's definite SUDEP. If there's no post-mortem and there's no other competing cause, like they've got, say, terrible heart disease or some other problem that might have caused death, then that's probable. And most studies, when they're looking at SUDEP in terms of populations, and I'll go through this carefully in a minute, are talking about definite or probable SUDEP. So possible and all those sort of things are generally not included. So what do we know? Well, we know a lot more than we used to. So in 2002, there'd only been 20 papers, worldwide literature, 20 papers on SUDEP published. And that's gone up tenfold or even more, a little bit of a drop, probably around COVID. So we're knowing more and more, but there's still more to know about SUDEP, amazingly enough. So a lot of the data is based on relatively small numbers of studies. And the first thing is, how common is it? Out there in the population, this isn't all patients, all people, everyone. So this is population-based studies, not people with epilepsy. There's a bit of data, and there's slightly dicey data, some of it's quite old, but the incidence per 100,000 people is about 0.6 to 0.8 per year. That's in all people in WA, if you like, or the whole population in the world. And there's some diciness about this data because this preceded some of the more strict and stringent definitions of SUDEP. But the important part of that data is that this is not necessarily a disease of the elderly. And so if you look at actually the age of the people who are dying of SUDEP, it makes up a greater proportion. It's one of the more common causes, neurologic causes of death in people in the age of 15 to 44. And that big green or teal line, that's accidents and sadly suicide, which is extremely common. 9 suicides a day in Australia. But neurologic deaths, SUDEP makes up more than half of those. So people who die between the age of 15 and 44, it's quite high likelihood of a neurologic cause, it's quite a high likelihood they died of SUDEP. But what about, as you know, with COVID studies, you can't sort of look at the whole population. You've got to really look at individuals at risk. And so if we look at patients with epilepsy, what's the rate in people with epilepsy as opposed to the whole population? And the way, instead of looking at 100,000, you tend to look at what's called patient years or 1,000 patient years, is that if you follow 1,000 patients for 1 year and one person dies, that'd be 1 per 1,000 patient years. So use a slightly confusing way of counting, if you like, the numbers of SUDEP. And in the general epilepsy population, so all comers, the rate's about 1 to 2 per 1,000 patient years. If you look at drug-resistant epilepsy, so patients still having seizures despite 2 or more drugs, that goes up quite a bit higher. And if you look at patients who get to the point of thinking about surgery or they've failed surgery, it's nearly 10 per 1,000 patient years. If you look at the whole lot, everyone with epilepsy, it's about 1 per 1,000 patient years. And so to put that in perspective, thinking about WA, a population of 2.5 million or so, about 0.6% of that population have active epilepsy. That's about 16,000 people with epilepsy in WA. And these are slightly dicey figures. But if we have an overall rate of 1 per 1,000 patient years, we're expecting 16 deaths per year with SUDEP. And I don't think we're seeing that actually, but that's how high it might be. Now, we may not be counting them properly. We may not be recognising them. We may not even know they're happening. They're quietly being called something else by the coroner. So this is a common problem. What age does it occur? Well, as I mentioned, it's the really incredibly devastating thing about SUDEP. It happens in young people. And this is population-based data, and big groups of patients sort of joined together. And the commonest age is between 20 and 50. So that takes 75% of people have SUDEP between the age of 20 and 50. But as you can see, it can happen at either end of life as well. And children are not immune from this. In fact, they were felt to have a low risk in the sort of 1980s, 1990s, but more up-to-date data, epidemiologic data, suggests that the rate is about the same, about 1 per 1,000 patient years in children below the age of 15. So children are not immune, and nor are the elderly, but of course there's so many competing causes of death as we age that it's quite a hard statistic to figure out. So how does it compare to other neurologic conditions? Well, as you can see, the big guys, Alzheimer's, stroke, dominate deaths when you're thinking about numbers. And so it looks quite small there. 3 makes up a small percentage of the total neurologic deaths. This is a USA study. But then you look at life years lost, and this is really an abomination. We're not spending more money. SUDEP contributes to the second most numbers of life years lost in USA of neurologic deaths. And so it's nearly as much as stroke. We're spending millions on stroke in WA to try and help stroke, and that's appropriate. Not a cent on SUDEP has ever been spent in WA that I'm aware of. And that's an abomination. We should be spending much more because it actually makes money for the state. We can save people's lives because these are young people and they're going to potentially work and pay taxes. So these big things, you've all heard about the ALS, dumping yourself in cold water. That's only half the number of life years lost. So this really puts in perspective how devastating this is. So let's jump to risk factors and clinical risk assessment. So the way you try and figure out if someone's got a risk for a disease is you get people who've got that disease and you compare them to people who don't have the disease. So for SUDEP, you look at cases, people who've died of SUDEP, and compare them to randomly chosen epilepsy patients who haven't died. And that's called case control studies. That's a pretty standard way to look at it. That's how we figured out smoking kills people. First ever case control study in the 1950s. And up until about 2011, there was actually very little data on this. Small groups, 50, 60 patients from relatively selected populations. And so till 2011, when one of the authors at the bottom there combined all the case control studies, there were only 200 cases compared to about 1,000 controls. And then a massive study came out of Sweden. So, they don't just make great sort of dark noir sort of movies for SBS, they do great epidemiology as well. And they looked at 255 SUDEP deaths and compared it. They had 5 controls for each case. So every case was matched to 5 other patients, matched for age and sex. Obviously, you've got to match people for age because if you get people of a different age, You might compare a 90-year-old to a 10-year-old, and obviously there's other causes of death in 90-year-olds. And that's where a lot of the data I'm going to be presenting is from that study from Sweden a couple of years ago. So coming to some of the risk factors, what are the epilepsy risk factors? What are the things that are about your epilepsy that makes you more at risk? And the key features is having tonic-clonic seizures. Whether it's 1 in the last year, whether it's 3 a year, whether it's having a tonic-clonic seizure ever, having a tonic-clonic seizure clearly is a massive risk. Not having a tonic-clonic seizure ever is a protective factor. You've got no clear increased risk if you've never had tonic-clonic seizures. That's not to say you're not at risk because of epilepsy. You may have a tonic-clonic seizure at some stage, but if you've never had tonic-clonic seizures, your risks are lower. And so the dominant epilepsy risk factors is having tonic-clonic seizures, and particularly if you're having more. And then one of the key issues there is having nocturnal tonic-clonic seizures from sleep. So not necessarily nocturnal awake, but nocturnal from sleep tonic-clonic seizures. And as you see, those odds ratio, if you like, that risk is about 10 to 25 times greater if you have tonic-clonic seizures, whether at night, whether in the last year or 3 in the last year. So that's a significant risk factor. There's a whole lot of other risk factors which are sort of really just markers of severity of epilepsy. So duration of epilepsy, the longer you've got it, the risk is cumulative. It's there. It just keeps getting greater and greater over time. Using 3 or more anti-seizure medications is a risk, but that's a marker of severity of epilepsy. There doesn't seem to be any data suggesting the type of seizure medication you're on has any factor. There was some noise about that over the years, but absolutely no evidence now that that's the case. Greater than 50 seizures a month, so obviously talking severe epilepsy there. And having intellectual impairment seems to be a risk factor as well. And then there's a lifestyle and sort of, if you like, domestic or social factors. And these are key factors, but living alone increases your risk significantly. Sharing a household but not a bedroom increases your risk as well. And so I sometimes joke with my patients, can you find a bed partner? Because that's an incredibly protective factor to stop SUDEP, but not that easy as we heard from Ben. Missing your meds, this is something you can do. Clearly missing meds doubles your risk of having SUDEP, and substance abuse, alcohol abuse, don't really need to go there. And so people have developed these risk factors into sort of scoring systems. And probably 2 or 3 years ago, these became a sort of hot topic. So people were being asked to fill in these forms and say, okay, tick the box here, you've got intellectual impairment or not, you're sleeping alone, all these things, and come up with a score for your risk. And these became quite popular and felt to be quite a useful thing. And we were all being told as doctors to be asking people to complete these. They're all biased towards severe epilepsy, and that's the big problem with these, because I don't know if you remember Flojo. She was the woman with the fingernails, amazing runner, and she died of SUDEP. Not really known, because the coroner said she suffocated in a bedding after having an epileptic seizure, which is a common thing to be written in lay press, that people that died of a seizure died of SUDEP. The mechanism was not suffocation, it's something else, which I'll show you in a minute. So Flojo, 1 seizure ever, 2nd seizure, she died. And if we did the risk score, her risk score would be very, very low, sort of 0 basically, or 1, because she's had 1 tonic-clonic seizure. Cam O'Brien from Melbourne, he had 2 seizures in his sleep. He was doing fine, found dead. So he had well-controlled epilepsy, and so he, again, wouldn't really be a person who thought to be at high risk. And so there's Emma and I were smiling. I'm not sure why, because it's not a topic we should be smiling away about. But we looked at people who died of SUDEP in WA, 36 patients between 2000 and 2018. And fortunately, a lot of them were my patients, sadly. And what we did is we applied the risk factor score to these patients, and we found that 25% would have been deemed to be low risk. And so we concluded that in real world patients, WO is the real world, we're going to miss 25% of people if we just use these scoring systems to say, okay, you're at risk, but you others don't worry about it. And so we may create this sort of false reassurance that people, oh, I'm not at risk, so don't really need to worry about it. That's possibly my most important point about this talk. So there's been efforts to try and bring this down to to something simple. Keep it stupid, keep it simple, stupid, or keep it stupid. if you really look hard at the major risk factors is tonic-clonic seizures and sleeping alone. And those two factors on their own just wipe out all the other factors. And so it's a SUDEP 2 score, not 7 score, not ever. So if I'm in clinic, I'm listening, are they having tonic-clonic seizures? And patients might say, well, why'd you ask me if I sleep alone? That sounds a bit weird. But that's a crucial question your neurologist should be asking you, because it may lead to an intervention, it may lead to different ways of managing or trying to detect your seizures. But looking at those two risk factors, if you have tonic-clonic seizures, sleep alone, it's an astronomical increased risk, 67 times increased risk compared to people who share a bedroom and don't have tonic-clonic seizures. Now, sharing a bedroom and having tonic-clonic seizures doesn't completely protect you, as you can see from the this little tower here, still 15 times risk. So, but those two factors are really where we, as neurologists, need to be stopping, listening, and trying to find a strategy when we hear those two together. Because we may be able to reduce that risk by intervening in some way. So what's the cause of SUDEP? Why do people die with seizures? And you talk about grim things. This is a pretty grim study, but a series of researchers gathered all the deaths that occurred during video EEG monitoring. So some of you had video EEG monitoring, as you know, we stop meds, want to see seizures, but sadly, or tragically, that's led to deaths in about 16 patients. And so these patients were on video and EEG, so you can have a look at it, and it's an opportunity to actually study the cause of death. And so they got out the videos and they looked at them carefully and tried to work out what was happening. And what they noticed is there's quite a striking similarity between the 10 patients they could look at really well, but even the 16, the key features were tonic-clonic seizures and from sleep. And what they saw when you look very carefully at what was going on, they all had tonic-clonic seizures. Immediately after tonic-clonic seizure, there's a brief phase where people seem to be breathing okay, often very fast, as you've probably all recognised when you've looked after someone with a tonic-clonic seizure. The heart rate was usually fast, and the EEG was flat. And then shortly later, seconds to sometimes a little longer, the first change was apnea, stopping breathing. And then the heart would stop. And I'm sorry if this is pretty confronting, but this is what happens. And so the sequence seemed to be tonic-clonic seizure, a brief period where things look okay, and then stopping breathing, and then if you don't breathe, eventually your heart stops. And that was the pattern in all cases where they had recorded deaths. So sort of summing that up, the brain has a seizure, the seizure ends, there's this flat bit, and that's where the problems arise, and stopping breathing, and then the heart stops. And this has actually been studied in a sheep model. Amazingly enough, they got the sheep and created seizures, and that seems to be the pattern in the sheep model. So it seems to be fairly reliable. We're still not 100% sure because, pleasingly, we're not having people dying of SUDEP, having monitoring very often at all. This is 10 patients in a worldwide study over several years. So there's more to be learned about the exact mechanism. We don't quite know what is going on. It's called the autonomic network. That's that automatic nervous system that tells us to breathe, tells us our heart to work. Something's shutting that down, and we don't fully understand what that is. So talking SUDEP, which is what we're doing today. And we've got major problems with this and strides to be made. So there's papers all over the place about what neurologists should know. But it should be what every doctor should know. It should be what every patient with epilepsy knows. But we, as neurologists, we try and educate other doctors, but the education has to be more global than this. And it has to happen with things like Epilepsy WA. You have to have a political sort of action to make people aware of it. But starting with doctors, what do doctors know? Well, these were neurologists in training, a survey in 2021, so not that long ago. Half of the doctors and neurologists in training, so these people are going to be a neurologist, had not had any formal education about SUDEP. Most of them had heard about it, and about half were aware of some of the risk factors, but they'd very rarely counselled or even talked to patients about SUDEP, even though they're seeing patients in the clinic. So that's in the US and in other countries. General practitioner knowledge, most general practitioners don't know about this. And I've had general practitioners call me and a patient's died, and we've talked about that, and they said, I've never heard of this. I wish I'd known about it. Maybe it's going to get better. There's a study from, well, it's an international study, but mainly from US, where about a third of medical students had heard of SUDEP. And so, starting with our doctors, we've got major problems with knowledge about this. And even if our doctors are knowing about it, are we talking to our patients about it? And the answer is no, we're not. And this is an old study, oldish study, 2009 in Scotland, Dundee. Only 4% of doctors, of neurologists, recorded they had a discussion about SUDEP with their epilepsy patients. So very few. 2006, a little later, UK neurologists again, 70% had no or very few SUDEP discussions with epilepsy patients. So the vast majority aren't talking about this in UK. And why not? What's going on? Well, there's a survey of 2021 survey of neurologists, global survey, and they asked neurologists, are they talking about SUDEP or not? And if not, why not? And a few other questions about SUDEP. And the bottom line is only about a third are talking about it, which is sort of similar to what it was like in the UK 15, 18 years ago. Only 5%, 1 in 20 patients with new onset epilepsy are having a discussion about SUDEP. And the sort of reasons the doctors were giving, undue anxiety, 43% have thought the patients were going to be upset about it. And as I'll show you in a minute, that's completely wrong. It's not the case. But maybe you guys can educate me, and maybe it is the case. Don't ask, don't tell, like the US military. Oh, if they haven't asked me, they don't want to know. Okay, good, well I won't tell them. And they made up nearly 10%. Knowledge doesn't change management. So 30% of doctors felt that patients informed about SUDEP wouldn't change their management, which is completely wrong. And there's no proven way to prevent SUDEP, which will show there are potential ways to do that. And so this study from Melbourne, similar sort of stuff in Melbourne in 2014, but they surveyed patients with epilepsy and asked them how much did they know, and 86%. So Melbourne, the home of epilepsy in the world possibly, there's more epilepsy specialists there than any other country in the world, just any other city in the world. At Monash, 86% of people who came to the clinic hadn't been told about SUDEP. This is our gold standard, this is what we're aiming for. 14% had heard about it. And when patients with epilepsy were asked how much did they want to know, 91% said, yeah, we want to know a bit or a lot about it. So this idea of patients don't want to know, this sort of paternalistic idea as doctors, we make decisions about what patients need to know and shouldn't know, is wrong when it comes to SUDEP, and a lot of other conditions, by the way. Another study of kids, which is a tricky group, because you're talking to the parents, but the parents clearly said they want to be told, they want early on, counselling early on, and they want a realistic appraisal risk. And they felt that wasn't going to change the way they interacted with their child in a negative way. So it's quite clear that we need to be talking about this more. And who do we talk about it? We probably need to talk about everyone with epilepsy, not selecting patients who are at risk. As we showed with our data, if we try and pick the patients at risk, we're going to miss quite a few people, about 25% of people who've got a relatively low risk of SUDEP. So preventing SUDEP. So what can we do? What things can we do? What epilepsy care options do we have to minimise the risk? And the first is this is really a very neurologic viewpoint, but picking the right drug at the right time. Using drugs where needed. Polypharmacy, and I know you've all grown about this, 2 or 3 drugs, even adding a 4th, and you say, crikey, what's Nick doing? He's adding another drug. Why is he doing that? I've probably heard you say, I'm having tonic-clonic seizure. I'm thinking, okay, I'm not happy here. What am I going to do? And there's no doubt that drugs do reduce the risk of SUDEP. So you might think, I'm taking these, I'm still having seizures, I'm still having lots of focal seizures or absent seizures, but we're really targeting tonic-clonic seizures with these drug add-ons in particular. And there's a real risk of it. This happens to us all, carers, parents, patients, doctors. We get this sort of complacency. We say, oh, okay, let's, if it ain't broke, don't fix it, whatever. Let's just push on. And I do this all the time. And we've really got to change that a little bit. We've got to sort of say, okay, well, what are we trying to do here? What are the risks of SUDEP? If we want to reduce that risk, let's talk about the treatment. And this includes, thinking about surgery, as we've heard from Rubin. But there is some data on this. I'm going to get these slides all together. It's a complex slide. We'll just, oopsie. This slide's a clever one. But let's get all of them up here. All of them up. So this is looking at patients who were enrolled in studies of epilepsy. Some of you might have been in studies where you're enrolled and you're having lots of seizures, and you may get the placebo or you may get the active drug. And then you come along to the clinic and we count the seizures and we say, how's it going with side effects? And so these authors looked at 112 studies of add-on therapy in epilepsy, so patients getting a drug added on to their treatment versus a placebo added on, something that doesn't do anything. And they found there were 20 SUDEP deaths in this group, so it was quite a few patients, 5,000 patients, but 20 in 5,000, so we're talking a pretty major risk here. These are mainly refractory epilepsy patients, drug-resistant epilepsy. But of those 20 deaths, 17 were the people who got placebo, which is obviously much greater risk than the 3 who didn't. So 6 times risk of dying if you got the placebo. So adding on these drugs does seem to reduce the risk of SUDEP. It's painful and there's a lot of side effects, but that's why we do it. And we shouldn't stop trying. We shouldn't stop trying. Oh, this is a little tricky one here, especially if there's tonic-clonic seizures. What about service responsiveness? And sadly, our politicians have gone here, but being responsive, and that involves obviously the carers and patients letting us know that things are going wrong. So if seizure ramping up, if tonic-clonic seizure ramping up, we need to hear. We don't say, oh, I've got an appointment in 12 weeks or whatever, push on. Someone needs to hear about it. If you've started having more tonic-clonic seizures, something's changed, because we'll do something about it. We'll probably change medications or look at what's going on. But we've got to be responsive as a service. And that means Judy answering the phone wherever she is, but it means as a epilepsy service, thinking of a global service. This is not just neurologists, epileptologists, GPs, doctors. We have to somehow combine our service. We've tried to do this. Epilepsy model of care is 15 years old and it's been systematically ignored. But we need more neurologists with expertise in epilepsy, but we also need more support for patients with epilepsy. And we need more people like Judy to be available to answer the phone, organise things, get you in the clinic or whatever needs to be done sooner rather than later, not just wait. Because when people die, when they're having more seizures, they haven't contacted us and we hear the tragic news. What about sleep and drugs and alcohol? I've talked about avoiding drug abuse, and that's self-explanatory, but monitoring devices, and that's really one of the major changes in the last few years. Up until 5 or 6 years ago, we really had no sort of adequate monitoring device. It was a baby monitor, some very sort of basic sort of monitoring devices, but that's really taken off. And these clearly work. They detect seizures. And we've got an opportunity here. So if you've got a shared household, or even shared household and someone in the bedroom, if you've got a device that can alarm and go off and bring a family member or carer into the room, that can be life-saving. So there's an opportunity here to intervene and maybe make a difference. And obviously these devices, what happens to the seizure, you all sort of know. Obviously the EEG is going crazy, but the heart rate's increasing, there's increased sweating, there's movement, there's respiratory changes, and all those things can be detected with devices. And so EEG, respiratory, heart rate, moving, sweating, all of those can be in some way recorded. And obviously the gold standard would be to record EEG. And that's on the way, I think, actually. Respiratory, look, there's obviously ways to record respiratory rate, but probably by the time they went off, if the patient's apneic and not breathing, it may be a bit late. But heart rate, movement, and sweating are the major 3 things we can currently record. Just a brief word on EEG. This is probably going to be with us soon. Obviously, the problem with EEG, you've all had EEGs, and so you've had prolonged EEGs, sitting on your head, getting sort of sweaty and sticky and sort of horrible after about 2 days. It's not practical to wear that for 10 years. But there are devices now, that ones inside the brain, which can sit there for years, called RNS. So these are ways of detecting seizures with electrodes inside your brain, on top of the brain. But there's now developments in a study in Melbourne going at the moment, where patients are having some electrodes slid between the scalp and the skull. So that sort of slightly spongy bit of stuff you've got underneath your scalp. You can slide electrodes in there, And then as you can see with the picture down here, it just looks a bit like a cochlear implant, but it's not. It's actually, he's got an EEG wire on his head. And that potentially then can be linked to a smartphone, iPhone or whatever, and record seizures and allow carers to get in there. As I mentioned, the pulse ox probably not that useful, but it hasn't really been utilised yet, and it might in the longer term be utilised. These are all over the place now because of COVID, everyone was wearing them, so they're very easily available. So we've got heart rate, movement and sweating, and I won't go over these too much because there's a whole lot of devices outside there, and there's a booklet which I advise you to get and read and check out these devices. If you're having tonic-clonic seizures, you should have one of these. Emma's there holding that's a mattress, in case you wonder what that thing is. It's a seizure mattress, but they're outside and you can have a look at them. One of the biggest problems is costs. Now, these are pretty reliably covered by NDIS, so if you are on NDIS, PEST or NDIS, they'll usually at least pay for the device, not necessarily the ongoing app, which is a few dollars a month. And I think we probably, as a group, whether it's doctors or patients or someone in between, probably should be pushing Medicare for rebate, like the blood sugar monitors that are free for kids under the age of 21 with diabetes. We have these for epilepsy patients provided by Medicare. And it's probably going to have to come from someone like Epilepsy WA to really push for it because, as usual, the government just thinks we're self-interested doctors trying to, push a political barrel or whatever. So that's one of the issues. What else can we do? Well, obviously surgery. We've talked a little bit of that. Vagal nerve stimulator, VNS diet. We won't go into that. They've been covered in previous talks. But if you're still having seizures, these things all need to be considered. But I still think the most important and empowering thing is knowledge, and that's why I'm talking today. So I'll stop there and take any questions if there are any.